Thank you, everyone. I would like to call the special committee on long-term health care to order at, what time is it? 3:13 on April the 10th. Madam Clerk, would you please call the roll?
Alderwoman Davis. Alderwoman Boyd,
Aye.
you present?
Present.
Christine Ingracia,
Present.
Kathleen Holmes,
Present.
Harold Braswell,
Present.
Lenny Jones, Marjorie Moore,
Present.
Laura Barrett,
Present.
Lavita Richardson, Victoria and Rory, Andrew Lackey,
Present.
Annalise Stover, Danielle Spradley, Chris Beckley, Tasanya Johnson, Jamie Opsel,
Present.
Cindy Jackson, Ellen Usher,
Present.
Reverend Kevin Anthony, Chair Middlebrook, Alderwoman Davis, Lenny Jones, Lavita Richardson, Victoria and Rory, Annalise Stover, Danielle Spradley, Chris Beckley, Tasanya Johnson, Cindy Jackson, Reverend Kevin D. Anthony, Chair Middlebrook. We have 9 present. We have a quorum.
Thank you. I'll be so glad when we go in person. I'm just so tired of hitting buttons. Okay, now we'll have approval of minutes for Monday, April the 3rd.
So moved. Second.
Okay, Madam Clerk, would you call the roll, please?
Alderwoman Davis, Alderwoman Boyd,
Aye.
Christine Ingracia,
Aye.
Kathleen Holmes,
Aye.
Harold Braswell,
Aye.
Lenny Jones, Marjorie Moore,
Aye.
Laura Barrett, Lavita Richardson, Victoria and Rory, Andrew Lackey,
Aye.
Annalise Stover, Danielle Spradley, Chris Beckley, Tasanya Johnson, Jamie Opsel,
Aye.
Cindy Jackson, Ellen Usher,
Aye.
Reverend Kevin Anthony, Chair Middlebrook, Alderwoman Davis, Lenny Jones, Laura Barrett,
Aye.
Lavita Richardson, Victoria and Rory, Annalise Stover, Danielle Spradley, Chris Beckley, Tasanya Johnson, Cindy Jackson, Chair Middlebrook. We have 9 aye votes.
Thank you very much. Now we'll have committee discussions, and Christine, so the committee discussions, it was Nathan, and could you all kind of update me on what he was going to be speaking on?
Sure. I mean, I think if it's okay with you, you can swear him in and he can give his introduction and then let us know briefly what he's talking about. Folks have been doing quick presentations around 10 minutes and then we're doing Q&A.
Okay,
Well, for you.
okay, that's fine. So, Madam Clerk, would you swear him in for me, please?
Yes, could you please raise your right hand? Do you affirm that the testimony you are about to give in this cause will be the truth, the whole truth, and nothing but the truth?
I do.
Thank you.
Okay, you're on, Mr. Nathan.
Well, thank you all. I appreciate the opportunity to come speak today. So my name is Dr. Nathaniel Dell. I'm the Vice President of Knowledge Translation and Impact at Places for People, which is a certified community behavioral health center here in St. Louis. I just want to clarify one thing. So knowledge translation refers to those strategies of applying and integrating knowledge that's generated in universities or research settings and figuring out how to apply those in day-to-day practice. And so that's a lot of what my work is at Places for People. So being in a community mental health center, I'm trying to bring that perspective to the issue of increased admissions of younger people with serious mental illness into long-term care facilities, and trying to look at some of the treatment and workforce development opportunities that there are for the community mental health profession. So first off, so at Places for People, I oversee all of our research, evaluation, and training opportunity or activities. And what we do is provide training and technical assistance on an array of evidence-based and evidence-informed practices. We work with behavioral health clinicians, people who are professionals, but maybe don't have a clinical background, and members of the general public to increase awareness, knowledge, and skills. So we really aim to promote a trauma-informed and recovery-oriented system of care for people with behavioral health difficulties. At Places for People, we serve about 2,800 people annually, primarily people living in St. Louis City and County. And even though I'm on this, able to speak to the committee today, most of our clients are living within the community. Nevertheless, there are a substantial overlap of the types of people who are entering into long-term care facilities with behavioral health issues and people that we serve in the community. So of those 2,800 people that we serve annually, if we look back over the past 3 years, we've really only had about 100 clients who have been flagged in our electronic health record as living in a skilled nursing facility. And when you look at people who are exiting our community behavioral health center, it's only about 5% of clients who, upon discharge, were living in a skilled nursing facility or in a long-term hospitalization or other long-term residential setting. So we are primarily working with people living in the community, and our aim is really to support people with serious mental illness and living within the community and not having to enter into a skilled nursing facility if it's not indicated. We also support people who are still in skilled nursing facilities. On average, there's about 40 people per month who are our clients who are in skilled nursing facilities. And we continue to work with them and try to promote rehabilitation so that they can reintegrate into the community. So I am not sure if all the different people have been able to speak and what information has been shared so far, but as probably we're all aware, over the past 20 years, we've noticed an increased proportion of nursing home admissions who are that are involving younger adults aged under than 65 who have serious mental illness. I just want to clarify that term too. So when we speak of serious mental illness, we're often talking about schizophrenia spectrum disorders, bipolar disorders, or major depressive disorders, where there's significant functional impairment too. So it's not just the presence of a psychiatric condition, but it's the impact on day-to-day living that characterizes a serious mental illness. So even though there's increased attention on younger adults entering into nursing homes, we are seeing an increase, a higher proportion of older adults who also have serious mental illness. So people aged 50 or older, and older adults with serious mental illness are more likely than their non-SMI members of the general public to enter into a long-term care facility. So I want to just draw attention to that as well. And this is something that the Institute of Medicine points out in 2012, recommending the need to identify, develop, and refine our curricula and curriculum development tools in geriatric mental health and substance use treatment to seek out effective models of training for integrated rehabilitation, health promotion, and healthcare for older adults with serious mental illness. Just in 2021, SAMHSA, Substance Abuse and Mental Health Services Administration, publishes a guide for peers, clinicians, organizations, and policymakers to better understand, select, and implement evidence-based interventions to support older adults with serious mental illness and living in the community. So it's an enduring issue. And when we look at national survey evidence or research, National Survey on Drug Use and Health from 2019, there's an estimate 3.4 million adults aged 50 and older who have a serious mental illness. Now that survey undercounts people, it excludes people who are experiencing homelessness and who are in long-term care facilities already. So we have a growing older adult population. Although older adults or although people with serious mental illness have higher rates of morbidity or mortality compared to the general population, we're seeing a growth in the older adult population with serious mental illness. And from a community behavioral health perspective, we need as a workforce to become more competent in geriatric health and integrated physical and behavioral health care to promote retention within the community. Nevertheless, the issue of increased admissions for younger adults into nursing homes is, of course, a pressing issue where we see estimates of about 3/5 of people admitted to nursing homes with schizophrenia being under the age of 65 when we're looking at Centers for Medicare and Medicaid Services data. We see that Medicaid beneficiaries with schizophrenia who are younger adults are 4 times more likely to be admitted to a nursing home compared to those without a mental illness. And we also see that residents with major depression, regardless of age, have higher rates of medical comorbidity, such as diabetes or COPD. And really these findings from research suggest a need to better integrate physical and behavioral health within long-term care settings, as well as within community-based settings to promote well-being. Younger adults with schizophrenia and other serious mental illnesses are more likely to be classified as low care status than residents who are age 65 and older. Despite often being considered low care status, younger adults with SMI are more likely to become long-stay residents than those admitted with other conditions. So there are perhaps, and I'm not certain, I can't provide an exact figure, but there's evidence that non-negligible number of adults with serious mental illnesses who are in nursing homes, whether older adults or younger adults, may have the functional capacity to live in less restrictive environments. But when I think of disability, it's not simply a function of one's individual functional status, one's psychological orientation. It's really an interaction of the individual with their environmental and social conditions that allow them to participate meaningfully in everyday life and to so it's not so there is perhaps this capacity there to be able to promote people's functional status to be able to reintegrate into the community. I want to talk about some of the strategies that we use within Places for People to promote community retention or reintegration. So people with serious mental illnesses show higher rates of co-occurring mental health, substance use, and chronic physical health conditions compared to the general population. So there's a multi-morbidity of behavioral health, physical health conditions, but people with serious mental illness often experience environmental factors that can increase the risk of becoming institutionalized, such as poverty, homelessness, social isolation, stigma, overlapping stigmas from age-related stigma, racial discrimination, stigma related to the diagnosis itself, and lower rates of employment as well. And the availability of health services can impact health status as well, of course. And so if we can ensure access to supported housing, supported employment, and supported education, and psychosocial rehabilitation services, we could advance the health and well-being of people with SMI such that they may not need admission into nursing homes or could potentially exit from those facilities as well. So when we look at surveys of long-term care facilities, staff often do feel ill-equipped to meet the needs of this growing population. And while those facilities should absolutely have access to the resources to support appropriate staffing, training, and access to specialty mental health care, I'd also advocate for more policies and resources to be able to expand access to care within community settings as well. So several practice models that we use within Places for People include assertive community treatment, which is a well-established evidence-based intervention. It's really an entire service model where there's an integrated treatment team working with people who have had a lot of interactions, perhaps with the homeless service system, the healthcare system, the legal system, and promoting retention into the community. ACT has been characterized as the hospital without walls, and so it's having the high availability of those services immediately accessible to the person without having to enter into institutional settings. At the same time, that's highly structured. ACT is also a very recovery-oriented practice that is driven by the consumer's needs and preferences. When I talk about evidence-based practice, I want to make it clear that it's not solely what the research evidence says. We also must consider the competency of the practitioners and fundamentally the values and preferences of the patients that we're working with. So when we think of evidence-based practice, it has to be trauma-informed, it has to be culturally aware and responsive. It's not solely what the research base says, but has to be an integration of what the best available evidence is, what the competency of the practitioner is, and what our needs and preferences of our patients are. So ACT is one of those that does have that evidence base. In addition, supported employment, supported education is a service in which people who have serious mental illnesses can participate in competitive employment. It's a vocational rehabilitation approach that doesn't focus so much on job training, but looks at rapid job search for competitive work with appropriate follow-up supports that help the person to sustain employment. In addition, permanent supportive housing is a model in which people have access to long-term housing housing with voluntarily wraparound services. And so the availability of permanent supportive housing, supportive education, and sort of community treatment models are all wonderful resources that we use, models that we participate within our community in order to help our clients live their best. I want to just comment briefly on a couple more interventions that we use within Places for People. So we use illness management, recovery, as well as helping ourselves pursue and experience success or hopes. These are psychosocial skills training and health promotion interventions that support clients in coping with distress. They support clients in understanding illness and creating their own recovery plans and building skills to be retained within the community and to pursue goals that are meaningful for them as well. So I was speaking with the developer of HOPES recently. It was initially developed for older adults with serious mental illness, but it has since been broadened to include any adult with serious mental illness. And one thing that we found is that it's not often integrated into long-term care facilities, but they've piloted integrating HOPES within one nursing home facility in the Northeast. Just a pilot study, but it seemed acceptable and feasible for the staff and residents of that facility. So I think there are opportunities for long-term care facilities to integrate these psychosocial rehabilitation services more routinely into their practice. And I think there's also capacity, or at least need for community behavioral health centers to offer these evidence-based practices as well to promote retention in the community. So the sort of workforce implications of this are to be able to better resource exploring which sort of training models and methods are most effective for community behavioral health workers as well as long-term care residents. So trying to find training that is acceptable and appropriate for the staff, that as many long-term care staff will not have a history or a background in behavioral health. And so we need to think of, given their time constraints and the workloads that they have, what are the best ways of reaching that section of the workforce to increase their skills, increase their feelings of competence, lead to better interactions with patients that they're working with, which could be a very empowering feeling for both. So I think in addition to the need for training, for a solid grounding and evidence-based practice. The last thing I'd like to emphasize is just the need to maintain a sort of recovery orientation. And so it doesn't, so we often work towards having an unconditional positive regard for the clients that we're working with, but it can be easier said than done. And I think that trying to maintain the idea that recovery is possible with the people that we're working with, and it has to be elicited from them and what their values, what their needs, what their preferences are. And that sort of grounding and sort of trauma-informed and recovery-oriented perspective is ultimately the foundation for this evidence-based practice as well. So I just want to share that perspective of, so from the community behavioral health side, how we approach our clients and where there are potential opportunities to collaborate with long-term care facilities and also some workforce development and training needs. So I very much appreciate the time.
Thank you very much. Is it Nathan or Nathaniel?
You call me Nathan.
Okay, because I was like, I don't want to mispronounce your name.
You're fine.
And so at this time, I'm gonna open up if any committee members have any questions for Nathan. Does anyone have I see Harold, you have your hand up. Yes, sir.
Hi, I'm pretty sure we've run into each other at SLU at some point. I can't quite remember where, but hey, see, you got your social work degree and doctorate from there. I guess one thing that would be amazing is if you can get, and I'll get your email and email you about it, how you got this figure of to estimate the sort of functional capacity of people in nursing homes, so that you could tell that, like, okay, like this number of people, or that there's a substantial percentage of people in nursing homes who could be living in the community if they were given adequate accommodation, supports, whatever you want to call it, in their environment. I think that's not really knowing much about this issue. That's an amazing figure to me that even exists. And I think that would be something really powerful if we could quantify that. I understand that, whatever, like we'll have to do whatever research is available, but even a little bit, just to make that point seems to me very crucial. And so any support that you could give would be wonderful in that regard, to get into the report. Beyond that, I mean, I think that the interventions, Places for People is outstanding. We're very lucky to have Places for People in the city. I am curious what you see city government, or maybe more broadly, if you had to think about the state or even national government, what could government do to facilitate some of the reforms that you talked about, or the ideas? Like, so for example, like having training in trauma-informed care in nursing homes. Probably a couple of things would have to happen to make that happen. You would probably have to do something with nursing home staffing rates to begin with, so that we could have sort of reasonable staffing rates, and then, questions of retention and things like that would also figure into it. But, just if you could just give us some ideas that, if we could do it, we could think about ways to integrate it into the report. For what would you like to see government be doing more to make it, specifically so that people wouldn't have to go into nursing homes until they really do hit that functional level?
Yeah, thank you. Those are a wonderful set of questions. And so when referencing the study that makes a claim that there is perhaps a non-negligible number of people who might qualify sort of low care status, they're using Center for Medicaid and Medicare Services limited data set. And so administrative data is great. I work with it a lot when doing research. We also must always be aware of the limitations of administrative data. It's collected for not research purposes. And so we must proceed cautiously with humility in interpreting this. But so if there was certain individual activities of daily living that were not coded in that person's chart, then there was the inference that then there's not the functional limitation present. And so it's through a survey of that. So that was the primary method used, but we should explore others. Within the community behavioral health setting, we're required to use a standardized tool for functional assessment to assess someone's levels of psychosocial impairment. And of course, there's the pre-screening that needs to happen before a person with serious mental illness could be admitted into a nursing home or other long-term care facility. However, that may not always function optimally as well. And so just relying on administrative data is somewhat precarious, but it can be helpful for getting an estimate. We just have to be mindful of the sort of limitations of it. In terms of the other questions that you had raised, I don't want to leave those off, but when we think of increasingly there's sort of a value-based care language that's being used, which it's one of those terms where it's hard to argue against. Why would you argue against something that's value? Why would you not want something that's value? But if there's a way of thinking of value-based care that really taps into the values, not just the payer, but the insurance payer, but of the clients and the staff and workers, as well, that would be important. And so if there are certain quality, if people with serious mental illness in long-term care facilities have higher rates of comorbid medical conditions, if there's higher levels of care that's needed, can there be policies that incentivize payment that provides higher level of care? If we see consistently across the board that people, when there are nursing homes with higher proportion of people with SMI, or 2010, we see studies that show that people with SMI are usually in lower rated nursing homes or lower quality nursing homes, or nursing homes that don't hit certain quality indicators, to be more charitable about it. But recently, 2020, 2022, we're seeing other studies that reinforce this finding 12 years later, 10 years later. And so I think we should consider ways and at the federal level, state level of rewarding those nursing homes that are providing higher quality of care for people with complex behavioral health and medical conditions. Thinking about what's ideal staff to client ratio. I mean, with the sort of community treatment, it's part of the standard that there is a low staff to client ratio, and that's not a negotiable aspect of that treatment. And so having models of treatment that are optimal for client and staff well-being, I think are important to explore and reward.
Okay. Did he pretty much cover what you were asking her?
He did. Thank you.
Okay. You're welcome. Ms. Laura.
Thank you, Alderwoman. So thanks very much for your informative presentation. That was super helpful, very dense. I'm going to have to watch this YouTube again, so I make sure to get all that, but really appreciate it. I think, it's pretty clear that Places for People is acting as an intervention agent, which is supporting people to live as independently as possible in the community, so that all of these different treatment modalities that you're able to apply to folks really do help keep people in the community. So I guess so congrats, it's fantastic work. Our studies of the CMS data, we uncovered that 40% of the folks who are in St. Louis City Medicaid funded nursing homes are listed through the CMS data as folks with severe mental illness. And so that when we compare that 40% to the 5% that you guys have that, end up in nursing homes, it's like those numbers don't add up in some ways. And so there's a whole bunch of people who are untouched by an agency like Places for People, and then just end up having no alternative, and they end up going into a long-term care facility, even though they may not need to be in a locked ward with, guardianship completely taken over by somebody else, and to have their independence so limited. So I'm just wondering, sort of like, who else is out there that's treating folks in the way that you guys are, or in a similar fashion. I also just really appreciate your comments about staff training. This is so important. So many of our folks who are part of the union, who are part of SEIU, come at this from a nursing perspective and are looking at physical health and not necessarily trained they end up doing it. They end up working, doing it de-escalation and doing crisis intervention and working with folks who have in a well-locked ward with folks who has severe mental illness. But that could be something that we really think about. On the other hand, I just also kind of wonder, are we just this weird anomaly? Is like St. Louis City, are folks just ending up here because the state of Missouri is not providing enough options for people? And that's why this is happening. So just wanted your thoughts about how, if you want to respond to that. Long question there. Sorry about that.
Oh, they're great, good questions. So when I think of deinstitutionalization, the movement of people living from state hospitals and being discharged from state hospitals happening from a legal legislation perspective in the 60s and accelerating in the 70s, rapidly accelerating over the 80s. There is this promise of deinstitutionalization that community mental health resources and funding would be made available to community mental health centers to treat more people within the community. And the sort of promise of deinstitutionalization has yet to be fully fulfilled, I believe, on a national scale, because even though we see over the past 20 years, increasing admissions of younger adults with serious mental illness into long-term care facilities, the legal system and nursing homes have been a core aspect of the care for people with serious mental illness since deinstitutionalization. So there was perhaps not enough community-based treatment at the time of that movement and continuing today, even though I think one positive aspect is certified community behavioral health center legislation that sort of sets up like a model of federally qualified health center, but from a behavioral health perspective. As a CCBHC, we're for the several years, we're the only one within the St. Louis region. There are others now and across the state of Missouri, but we're required to serve anyone regardless of ability to pay, or we offer services that are developmentally appropriate throughout the lifespan. We work with people, I talked a lot about serious mental illness, but we have co-occurring substance use, mental health disorders, people with substance use disorder, youth, families, and so we aim to serve people across the lifespan. I think legislation that supports that sort of diversity of treatment options for people and that lifespan developmental approach is a strength and should be more replicated, I think.
Okay, did he answer your question, Laura?
Yes, he did. So
Okay.
you guys are the only federally I'm sorry, I do have one more question. You guys are the only federal qualified health clinic in St. Louis for mental health.
For the first several years of the Certified Community Behavioral Health Center demonstration program, we're the only ones, but I believe VJC and Hopewell are also CCBHCs at this point, and there are others throughout the state of Missouri now.
No, I don't see the difference.
Okay, all right, so let me first apologize because I did not know the parameter of how you all ran this meeting. So I do know Christina said the speaker had 10 minutes. And I know previous meetings, we only allowed 3 minutes for each, question and response. We have to shut down at 4 o'clock because we're being respectful of people's time. And so I'm gonna let Marjorie ask her question and then Nathan respond. Is that fine with you all? Okay. All right, go ahead, Marjorie.
Thank you. Thanks again, Nathan, for a great presentation. You and I have talked a lot, Voice and Places for People work together a little loosely. I think it would be helpful for the committee to hear about kind of what happens to your long-term clients and their relationship with Places for People when they move into long-term care.
Yeah, thank you for that point. I'll try to be brief. So we recently created a position where these are where we have a person who continues to work with people who are in skilled nursing facilities. So those are services that we cannot bill for as an agency because they're already receiving those all the services through the SNF. But we care about the sort of continuity of care with the people that we work with and want to remain as an advocate in that person's life. And so we'll not immediately discharge a person all of the time when they are entering into a SNF. We have a special position dedicated to working with people who are in those institutions.
Okay, was that it? Marjorie, okay, all right, and so I guess, Nathan, from coming from the long-term care, environment, because I worked in long-term care for, quite many years, and so over 25. And what I had saw was, it was less being given to the employees and more being given to the owners. And so that has always been an issue with me in regards to long-term care, because I feel that as long as you treat the staff good, they're gonna treat your clients good. And so what I'm hearing from Places for People, and thank you for the presentation, you kind of educated me on the organization because I did not know that that's what you all did. So I guess my question is, and I did hear Harold say that, you know, governmental, how can we look at this? And I guess my thing is, we long-term care started getting people with mental illness and people under 40. I said at least 5 years, 10 at the most ago. And I don't think people realized it. And so my question to you and to this group, I think, is it better to look at not having them with those seniors and to have them in a whole nother area, a building or whatever, to set up just to focus on those? Because 9 times out of 10, those facilities are getting those people from the ER. And when it first started happening, those facilities were not prepared for that. And they still aren't prepared for it. They're unprepared to mix the apples and the oranges. So from Places for People perspective, do you look at another way that that can be infiltrated? Yeah, the staff probably needs training, but also those people need to, well, not those people, I don't like putting it like that, but people that have those illness need to be put in an environment where they can actually get help. That's what I'm thinking.
Yeah, thank you for that statement and question. And I want to proceed with humility on account of not having experience directly in long-term care. And so I'm not sure from a legal perspective, I'm not sure to what degree people can be partitioned into different care settings, but I think there are ways potentially of exploring how can we provide for developmentally appropriate services for people that are interventions available that are helping to meet their needs and to promote rehabilitation, whether that means reintegration to the community or just getting along better day to day in the facility as well. And so I think having services that directly meet those needs of people with serious mental illness would be recommended, or I would recommend that. And yeah, we'll have our clients who will need to enter into SNF at different times. I don't know. Sometimes it's a mix of, is there available housing? Is there appropriate access? Is there access to appropriate housing? That's a huge issue for us and many of the clients that we work with who are experiencing poverty and really severe material deprivation. And so I think there's this other aspect of what programming can long-term care facilities really offer, because it takes time and financial resources to invest in a highly trained and skilled workforce. But then also what sort of housing supports can we make available in the community that could be appropriate for keeping people out of those situations as well, if possible.
Okay, thank you.
Thank you.
Any more questions, comments? Okay.
Sorry, Alderman Boyd, just really quickly, one more question. Nathan, does Places for People have housing?
So we work with Gateway Housing First. They manage the some of the residential care facilities and group homes, and we provide services to them. So previously, we were both in that housing administration and service side, but now we provide the services alone. So yes, we continue to staff the permanent supportive housing and residential facilities.
Very helpful. Thank you.
So we need the housing all the way around, correct?
Correct.
Right, okay, all right. Okay, on that note, do we have any announcements? Yes, sir, Harold.
Sorry, very chatty today. So for the 24th, I had talked about this in the previous meeting with Chair Middlebrook and other people as well. I've been in contact with David Barton Smith, who's a health policy scholar and historian in Philadelphia, about the topic of basically housing discrimination and long-term care settings and sort of the relationship with that. He has said that he could come in on the 4th. I just wanted to check if it would be okay if I could confirm that with the committee. I know we need to kind of restart next week, but would it be okay if I booked Dr. Smith for the 24th?
Well, it's supposed to be Amir. Remember, we had discussed up front that she would come next. And so we could take your guess for the next one.
We sometimes do two people in one meeting.
And I guess my question is because people will learn, I'm a respecter of people's time. So where is the committee as a whole on that? I don't want to make a decision. And I understand people's schedules or, you know, the way things are going now, people's schedules are crazy. So where's the committee? Where do you all feel? Marjorie, you had your hand up.
Yeah, I think 2 per session is fine. Actually, I think at one point I thought I was supposed to speak today too. I am happy with being rescheduled again because we're running short on time. But yeah, I think 2 per session is usually pretty doable.
Anybody else? Laura said okay, Jamie said okay, Kathleen, Ellen, I didn't hear anything from you guys.
I'm okay with it. This is Ellen.
Okay, all right, Harold, so the committee has came together and said that they could take 2. And so we'll make a note of that, and then Marjorie will be on the next meeting after that. And then that way we would have accommodated, and so
Actually, that meeting I can't talk at. I will be out of the country. Maybe the one after that.
okay, all right. And so also I'm a result based, and so I know we have been meeting for a while. So I would really like to make sure that at the next meeting, we kind of look back to see, you know, what our goals have been, what we have accomplished, and what's our next steps. Okay, all right. Any announcements? Okay, all right. I'm sorry. I didn't print out my thing, so I'm trying to look at the
There
see
were none.
things. Okay, so no announcements. And so Nathan, thank you so much for coming. You gave a lot of enlightening information that I know I didn't know about. Like I said, I heard about places for people, but I didn't know you all did all of that. And so could you Madam Clerk, excuse all the people that weren't present?
Yes, ma'am. Did you want me to name those or you just want me
Yes.
to? Okay, so, okay, we're gonna excuse Alderwoman Davis. We're gonna excuse Lenny Jones, Lavita Richardson, Victoria Ann Rory, Annalise Stover, Danielle Spradley, Chris Beckley, Tasania Johnson, Cindy Jackson, Reverend Kevin Anthony, and Alderwoman Lisa Middlebrook.
Okay. For letting me present today. Oh, you're welcome. Yeah, you're so welcome, Nathan. Okay, on that note, we'll call the meeting to adjourn. Does anybody have any objections? Okay.
No objections.
All right, the meeting is adjourned. Thank you all so much.
Thank you.